We're going to get started here. I am recording this session, but welcome to the Excelerate Heart and Vascular series. This is our end of year series, so we offer 2 opportunities throughout the year to participate in a membership-wide webinar. So today we've partnered with Penumbra to bring forward the most recent findings from the STORM PE trial. We will also briefly hear from Nancy from Penumbra, who will recap on a previous webinar we had earlier in the year around the findings from the computer-assisted vacuum thrombectomy, which will segue us nicely into a presentation from Dr. Benenati. So we look forward to that. We will have ample time at the end of this meeting to answer any questions or field comments, but I do ask that you use the chat feature here in Teams as we walk through the presentation. I'll also put on the screen 2 poll questions for you. One's going to be a couple minutes into the presentation. The second will be at the very end. So I kindly ask that you participate in those questions as it helps us during this presentation. So this is going to be informative. We look forward to this. We have a lot of members that have joined us this morning. So this is obviously a topic that people find highly interested. So with that, we'll first hear from Nancy and then Dr. Benenati. But with Nancy, with that, I will hand the presentation off to you. So thank you.
Thank you, Tim. Penumbra is a global healthcare company. We're focused on innovations that add value to the hospital and your patients. Our focus and our goal is to increase patient outcomes and decrease the overall cost. Penumbra first received its roots in treating stroke before translating that technology to the rest of the body. And Penumbra has since remained a leader in thrombectomy, head to toe. Our devices are designed for safety, speed, and simplicity. Studies have supported CAVIT, computer-assisted vacuum thrombectomy, with a low risk of major adverse events and minimal blood loss. That computer algorithm within our catheter assists with quicker clot detection and differentiates between patent flow and clot. A quick recap on our last presentation to the Heart and Vascular series earlier this year. Penumbra had partnered with Vizient, our largest GPO partner, to look at the treatment of intermediate risk PE using a retrospective observational analysis. And the data was then analyzed using propensity matching. This database included 34.5 million patients and ranged from 2020 to 2023. Propensity matching is taking 2 patients of similar demographics and then comparing the treatment models. The treatment models included were anticoagulation, mechanical thrombectomy, catheter-directed lysis, and CAVIT, which is Penumbra's portfolio of Lightning products that many of you might already be familiar with. Big picture, patients treated with CAVIT had better outcomes across the board, including a decreased length of stay, decreased complication rates, and a decreased total procedural cost as compared to other modalities. There's also the economic impact of using CAVIT, including a higher reimbursement and a decrease in overall cost. CAVIT has a $10,000 contribution margin advantage as compared to anticoagulation alone. Knowing the economic benefits of CAVIT, we will get into the clinical benefits today, as supported by the landmark randomized control trial, STORM PE. Before we start, you should see a poll pop up on your screens now. How does your team primarily treat patients presenting with intermediate high-risk pulmonary embolism? As you are all putting your votes in, please help me welcome our speaker, a thought leader in the endovascular field. He has authored over 150 scientific publications, is a clinical professor of radiology, has spent 31 years practicing at Baptist Health as an interventional radiologist. He has served as medical director of the lab and was also a fellowship director. He is now the chief medical officer at Penumbra. Welcome, Dr. Benenati.
Hey, Nancy, thank you so much. It's a real privilege to be here and to be able to do this. And also it's really nice to see on the participants list a number of old friends and people who I've known for a long, long time. So I'm going to get into a little bit today about this randomized controlled trial that we just finished. And I'll give you a little bit of background on this. And this is simply went like this. About 4 or 5 years ago, we realized that in order to move this field forward, we need to get some real data and we need to look at how we perform compared to anticoagulation. There's wars going on between companies about devices, whether it's thrombectomy or thrombolytics, and how we're doing. But the underlying point that everybody has to realize is that for potential patients who could be treated, patients who we consider good candidates, only about 20% of the market is penetrated, and that's a bit generous. So 80% of the market hasn't been penetrated. That means around the country, 80% of the time, there's a 26-year-old woman on birth control pills with a PE who's short of breath, whose life may be at risk, or at least long-term functional status may be at risk. They're not being offered any type of treatment. And until we can grow that number of 20% penetration to 70 or 80% penetration, fighting amongst each other isn't going to grow this field. And my thought was we need to do something to grow the field. So we wanted to run a randomized trial. Now, as a bit of a background, there are other randomized trials that are still being run. The issue is, as the trials get larger and larger and ask more and more questions, they take longer and longer to be completed. So we wanted to design a straightforward trial that we could complete that would show us a benefit to anticoagulation. And that was the purpose of the STORM trial, which is the first randomized trial of thrombectomy to anticoagulation. We can go to the next slide. And I'm just going to have Nancy advance for us. So as this basically goes through a good bit of the things I just told you, currently there's 7 FDA thrombectomy devices cleared. I can tell you from doing market analysis within our company, there are 32 companies right now trying to get approval for thrombectomy in the United States. If you are anybody who's a little older, if you go back 10 years, there was nothing in this space. This space just exploded since the mid-2000 teens. But we recognize that it exploded because there is a real need for patients who are having problems. And it's been over a decade since there's been any randomized data to anticoagulation alone, and that was with thrombolytics. And let's all remember that back in 2013 and 14, when these trials were done, anticoagulation therapy was very different than it is now. Everything was unfractionated heparin converting to Coumadin. So even in prospective single-arm trials, when we're looking at historical controls and how patients did with anticoagulation, we're looking at antiquated data. So part of our goal here was to run a randomized trial for thrombectomy, and the other part was to look at updated outcomes with anticoagulation, so we would have real life, real world data that was meaningful, because no one anticoagulates patients now the way they did 10 years ago. So this is the first trial to really look at this. Next slide, please. So we decided to use RV-LV ratio as an endpoint, and I understand that there are probably a lot of people listening to this that say, oh, RV-LV ratio is only a surrogate. It seems to be this kind of new mantra that's out there. But I would ask you to go back and think, any of you who treat PE, and define PE as low risk, intermediate low, intermediate high, or high risk, massive or submassive. Use any category you want. What is a common denominator in all those definitions? It's the RV-LV ratio. So when people say, oh, I don't care that much about it, you have to care about it. It's how you define your PE group. And the reason it's used in all these definitions is because it's associated with a twofold increase in the risk of early death when it's elevated, and threefold increase in risk of PE death. Okay, so small changes in RV strain can affect the RV-LV ratio. Now, it is a surrogate, and what we're going to show you, what we did in our trial, I can't speak to other people's trials, is for those who say, well, it's just a surrogate, I want clinical endpoints. We identified the clinical endpoints that the RV-LV ratio actually define, and we looked at those individually. So I'm going to show you in this trial those clinical endpoints that the RV-LV ratio is a surrogate for and how they did. So let's go ahead and go to the next slide. So what we did is we looked at the change in RV-LV ratio. So can we make the right heart recover in 48 hours? We strain the right heart with an intermediate high-risk PE. Can that heart recover quickly? And that's really the question we want to ask, as well as a number of secondary endpoints. Now, we did use a blinded, independent, not related to Penumbra, an outside company CRO set this up. We have a core lab to look at everything. So there's no physician bias in measuring or doing anything like that. The FDA, to get a new device approved on the market, requires a trial that's powered at about 80%. We powered our trial at 90% so that we would have a highly powered trial so that our differences would be meaningful and significant. And the question we wanted to show is we wanted to show superiority, not equivalence, but superiority of using our technology over anticoagulation. Next slide. So we had a number of secondary endpoints. Of course, safety is one of them. We looked at mortality. We looked at recurrent PE. We looked at major bleeding, all early on. Next slide. And then we looked at a number of other things that I'll get into in a little bit that include 6-minute walk test and many functional outcomes. So you've seen these slides. You've seen this in your previous presentations. The device here was our Flash 2.0 catheter. We used a 16 French device in the vast majority of these cases with our Penumbra pump. Now, I will tell you that the newest technology Penumbra has, when this trial started, was released just a few months before the trial. So we had a lot of centers that had almost no experience with our product, and we only required 2 cases experience to enroll in this trial. And I would ask you to go out and look at many randomized trials and the experience that's necessary. The fact that you could do 2 cases and still be part of a randomized trial and enroll and get the results we have speak to the ease of use and the safety of this device. And we'll see that in a little bit. Next slide, please. So this was an international trial. We had sites in Australia, sites in Europe, and sites in Canada, as well as the US. We had standard inclusion criteria that included a PE within 14 days. We needed to have a CT on everybody. While our other trials that we're currently conducting, we have a large trial that's enrolling over 1,000 patients right now. We allow echo. To use a core lab and really measure things, we required CT. And everyone had to meet the criteria for intermediate high risk, which is biomarkers and elevated RV-LV ratio. We exclude patients who had high risk PE or massive PE and patients with a known history of CTEPH. We allowed cancer patients into the trial, something a lot of trials don't do. We excluded primary and metastatic brain cancer because all patients had to be anticoagulated. We asked that patients have a life expectancy of greater than 90 days. Next slide. So the patient flow went like this. We screened 767 patients to get 100 patients. Now, let's just sit on that for a little bit. That seems like a lot. If you've been part of a randomized trial, you'll realize that's an outstanding number. We've been part in my own clinical practice for fibroids, for HIFU, carotid stents, endografts. It sometimes takes 15 to 20 to 1 ratios to get a randomized patient. Remember, it's hard to randomize, right? A lot of patients don't mind entering a clinical trial that's prospective and single arm because they're getting the benefit. But when you have to explain to someone they may not get the benefit, that's tough. And with that, we still had a 1 to 7.5 randomization rate, which I think is really outstanding. We did allow patients in the anticoagulation arm to cross over. So from an ethical standpoint, patients who got into the anticoagulation arm and did poorly were allowed to cross over. What does that do? That allows us ethically to treat patients that we know might crash. It also works against penumbra if we really want to be biased, because it takes patients, it prevents mortality in the anticoagulation arm. But it was something that we thought was absolutely necessary to do. We ended up by coin flip 53 patients in the anticoagulation arm, 47 in the CAVT arm. Next slide. So what did we do? We evaluated patients at baseline, and then these are all the way out to 90 days. And each evaluation, we had clinical, anatomic, and functional outcomes assessed. And you can see here that we used 3 quality of life metrics, a 6-minute walk test. We looked at the amount of clot with a modified Miller score. We looked at the PVFS, which is a functional questionnaire about how patients do before and after their PE. We looked at Borg score, which is a breathing scale, and we tracked all of these out to 90 days. The news score, I'll explain to you, many of you may know, but that's a score that rates people and assesses whether or not they're stable, and it predicts whether they're going to crash. And we used in other trials that have been done where they've allowed crossover, they allowed it to be physician preference. That introduces a huge bias. You could say, oh, this patient doesn't look good, and you can cross them over. We used an objective scale called the news score, the news 2 score, so that you couldn't cross over unless you met certain objective criteria. So everything was done objectively. Let's go to the next slide. So baseline, we had very excellent match pairs. When you look at age, when you look at race, when you look at sex, when you look at medical history, everybody's pretty similar in both the anticoagulation arm and the CAVT arm. When we look at the baseline clinical parameters, they're very virtually identical with all the clinical parameters you can see on the far right in the red box. Next slide. So baseline functional assessment, when we, again, everything very well lined up. They were well matched, so there was no bias introduced early on with one group being different than the other. Next slide. The anticoagulation strategy, we allowed physicians to do what they normally do, but unlike older trials, low molecular weight agents and rapid oral agents were used to anticoagulate patients. And one of the things we did is we followed this out. We had 48%, at 48 hours, we had 90% basically in both arms, roughly 90% of patients fully anticoagulated. Anyone who practiced a decade ago with heparin knew that only a small percent of patients were truly anticoagulated at 48 hours because you were titrating heparin doses up and down. So this gives us an excellent baseline that equals both groups, makes everything equal. And when we follow the patients up, I'll show you some data on the anticoagulation that we didn't have before that really is helpful to us. Let's go to the next slide. So the procedure, let's just go over some technical details unrelated to the RV-LV ratio and clinical outcomes. Thrombectomy time in this procedure was 25 minutes. That's the quickest reported time to remove clot in the literature right now today. There's no thrombectomy device or lytic device that has times at 25 minutes. Total procedure time that stick to groin, to pulling from the groin or the jugular in 56 minutes. The estimated blood loss was 296, no transfusions. 296 blood loss is actually nominal or minimal. We know we lose that easily on TIPS, endografts, complex arterial cases. So that ended up not being a problem at all. 100% technical success defined as the ability to put the catheter into the clot. And then we'll get into the clinical stuff, the PA reduction as we go. So again, no transfusions and no access site complications. Let's go to the next slide. Now, the primary efficacy endpoint, the RV-LV ratio, when we look at where we started to 48 hours, you can see a profound difference in RV-LV ratio. Now, interesting to note, anticoagulation alone has a statistically significant improvement in its ability to reduce clot. And we know that. That's the standard of care. And with the newer agents, we actually do better than we used to do. But CAVT compared to anticoagulation, there's a profound reduction, not just in the change, but in the absolute reduction. Okay, so between the two differences, there's almost a 30% reduction improvement in CAVT compared to anticoagulation, and that P is 0.001. So highly significant, highly powerful change using CAVT to anticoagulation. Let's go to the next slide. Secondary safety endpoints, there is no statistically significant difference in any category we looked at, including major bleeding, major adverse events, device or procedure adverse events. One thing that should catch your eye is that there were 2 PE-related mortalities in the CAVT group. I want to just address those now because some people have criticized us about this. Neither of these were adjudicated by the independent CEC committee to be device or procedure related. So let me address each one. The first patient, 5 days after the procedure, developed a DVT in the left leg, the leg that was not treated. The patient was brought to the interventional department and treated by a physician who was not part of the STORM trial. They used our competitor's device, a device that you all know very well, and they pushed clot into the lung, and the patient expired on the table with a new PE unrelated to the original PE. It just was bad luck. It ended up in the CAVT arm. It had nothing to do with the procedure, and in fact involved a competitor's device performed by a physician who was not part of the trial. The second patient had pathologically proven, autopsy proven, reperfusion, had an infarction with reperfusion hemorrhage and died from that. Device was out of the patient at the time of the bleeding, and the adjudication and the autopsy report showed no perforation, no trauma to the lung, and no evidence of a device-related injury. Adjudicated as not related to the procedure or the device. And those are independent adjudicated events that are done by a CEC committee that is not picked by Penumbra. It's picked by an outside CRO who we contract with, and we have no contact with those physicians. Next slide. The mortality through 90 days, you can see, is statistically not significant in the CAVT arm or in the anticoagulation arm. There's essentially no device-related mortality and no PE-related mortality after the 7 days. There were deaths in each arm after the 7 days related to malignancy, unrelated to PE. There was one patient who had failure, who was enrolled, who had a stroke 2 days prior to the procedure with a pneumonia and still was enrolled and died of failure to thrive despite having a markedly improved RV-LV ratio. So there statistically, there's no p-value significance after 7 days. No, and if you look at the life table, there's no real difference out to 30 days. Next slide. Now, the safety events, I mentioned these things. I don't think we have to go through them again. We did have on the anticoagulation arm 3 patients who had to convert over with NEWS scores greater than 9 or greater. And I'll go over the NEWS scores later, but this is related to their pulse and their clinical outcome. These were patients who were crashing who may have died if they were untreated or certainly deteriorated. They crossed over. We allowed in the crossover any treatment. So the patient on day 3 needed to receive a lytic and thrombectomy. The others received just thrombectomy. So there were 3 patients of the 53 who needed rescue. Let's go to the next slide. When we look at the clot removal maps, you can see the anticoagulation on the bottom versus CAVT on the top. When we look at thrombus burden, no one has done this in any trial, looking at anticoagulation thrombus with modified Miller scores. So we've mapped out the amount of clot. This is going to be exceptionally helpful to all companies, to all data in future trials to understand how well anticoagulation works. We map that out in the anticoagulation arm and in the CAVT arm, and there's a profound reduction in clot using thrombectomy compared to anticoagulation. But we do know that anticoagulation will reduce 15% of the clot. So, and that again, 0.001 significance, highly significant. So let's go to the next slide. So 2 very big points here. What happens to heart rate? Okay, look at the heart rate change at 48 hours in the anticoagulation group on the top versus the thrombectomy group, and the number of patients who remain tachycardic at 48 hours. And I think all of you know that when we use a PESI score and a NEWS score, heart rate is probably the single biggest indicator of a patient having a problem. And it's one of the major endpoints used for procedure endpoints. 20% of the anticoagulation group were still tachycardic, 2.2% of the thrombectomy group. Highly significant p-value. So this is part of the reason why the RV-LV ratio is valid. This is what the RV-LV ratio is showing us. It's a surrogate, yes. What's it a surrogate for? It's a surrogate for heart rate, oxygen requirements, and deterioration. And here is one data point that validates that RV-LV ratio. Next slide. Additionally to that, let's look at oxygen requirements at baseline and 48 hours. And you see a huge difference in supplemental oxygen needed at baseline and 48 hours. Significantly lower supplemental oxygen requirement, again showing you that you're rescuing the right heart. Next slide. The NEWS score is here on the right. That's the respiratory rate, supplemental oxygen. All these components go into this. And when we look at the NEWS score changes, again, we see that the NEWS score is significantly lower in the CAVT group, the CAVT group. So again, we have 3 now clinical endpoints, the ability, someone deteriorating their oxygen level and their heart rate. And I think these show you why rescuing the right heart is important in the short term. Patients are going to do much better in this group that get thrombectomy. Next slide. Functional endpoints, Borg score, and dyspnea scales. So if we look at this, there's no significant change at at discharge in the breathing scale, but a significant trend. When we look at 30 and 90 days, these numbers will become significant. So while we see a trend in the beginning, it's going to be significant when we get out later on. So let's go ahead and go to the next slide. The PVFS score is a functional ordinal scale. It's composed of 6 questions. And what we find in this, when we compare patients to their pre-PE state, they're 2.2 times more likely to return to their pre-PE functional status than those who get anticoagulation. So this is a good patient-centered clinical metric that tells you how patients are doing now compared to prior, and they're 2.2 times more likely to be normal and return to their normal baseline state. Next slide. So 6-minute walk test. Let's look at this at 90 days and 30 days. If you look on the left, you'll see that there's a significant difference at 30 days, and the procedure is durable. Patients improve more. So maybe their groin was punctured, maybe they're still a little tenuous in walking, but at 90 days, that number widens significantly. So the distance that you can walk is profoundly different, almost double in the CAVID arm. Now, if we go to the next slide, in addition to how far you can walk, there are metrics that tell you what your predicted walking distance should be based on your weight, sex, age, everything else. And you're much more likely to return to your predicted walking distance. Not just can you walk further, but you get back to your normal distance, much more likely in the CAVT arm again. Next slide. So in conclusion, this is a first randomized trial to look at anticoagulation versus thrombectomy. Okay, we show that we have a superior reduction in RV-LV ratio, similar safety profile. So we don't increase the risk, but we increase the ability of patient to recover. Okay, treatment, early physiologic recovery is clearly profoundly different. We see that with multiple clinical outcomes validating the use of the RV-LV ratio. We see at 90 days, we have longer functional outcomes, better functional outcomes. Probably the most important of those is a 6-minute walk test. And we think that we now have an effective treatment strategy that can provide early recovery for patients. Next slide. This has been published in Circulation. If you want to read it, you can scan the barcode. We have a second publication being submitted to Circulation in the next 2 weeks with all the secondary outcomes that haven't been presented here. We've tracked everything out to 90 days. We didn't have all that data when this was first published, but Circulation still found this to be of extreme value and published this. Next slide. You can also find out more about the trial in another journal. Next slide, we can go on from there. And then the other thing I wanted to point out, there was a slide. We had a steering committee here. It's very important to point out that this trial was designed. The trial idea was my idea. I brought it. Yeah, can you go to that steering committee? But we partnered with PERT. Please, next slide. Next slide, please. We partnered with PERT, and this trial was designed with past presidents, current and future presidents of PERT. We had 4 non-interventional physicians on this to eliminate all the bias that you might get from interventional physicians. We had an international steering committee, and this is a first PE trial that actually had a patient on the steering committee, a patient who had a massive PE or a high-risk PE and was rescued and survived with that. So I think the steering committee introduced first of all, they helped in the design, and secondly, I think by having the non-interventional physicians, we eliminated a large amount of bias that interventional physicians might have had if it was done by them alone. So I'll stop at this point and answer any questions that you might have. Thank you very much.
Thank you, Dr. Benenati, for that very great detail there and diving into that and explaining that clinical trial for us. But yeah, open up to any discussion, comments, questions. I know there was some technical difficulty with the poll question, but we did get a sampling there that said the primary treatment was a combined approach. So anticoagulation, mechanical thrombectomy was the leader there from the responses that we got. But with that, we'll open it up.
I might, while we're waiting for some questions, I can mention that in all fairness, there are other randomized trials going on right now. So everyone knows there's a large NIH-sponsored trial, PTRAC, that's probably several years out. There is HiPytho, which is a thrombolytic trial, which will be presented in April or May of this year, which looks at thrombolytics. And then there's a competitor's mechanical thrombectomy trial, which is still a bit out from being answered. But our goal here again was to get data out early to show immediate recovery. And now we can track these patients at a much, out a lot further. And we were able to do that again with a high level of significance and only have to enroll 100 patients. Any questions, criticisms, comments? Be happy to take it all.
Yeah, I don't hear any. I don't see any questions in our chat function here. All right, hearing none, we'll close it out. Thank you so much. We
Okay.
appreciate the partnership with Penumbra and your time, energy to walk us through that and the impact this will have for care management. So thank you so much for that. We'll be looking to hold another webinar in Q1 of next year, so look forward to that. But again, we appreciate all of the audience attendance here and listening. So thank you.
I think he was miffed by the decision with Kurt and Hannah, right? I think he was like, that was, there was, I think he totally.
All right. Just some background noise, but thank you, everybody. Y'all have a great and wonderful rest of your day.
Thank you.
Hey, Tim, thank you so much. Thank you very much for letting me be here. Really appreciate it.
Yes, sir. Thank you very much.
Thank you.
Thank you.